Guys, how many in your group? Guys, how many in your group?
9, Doctor.
Sarati, how many in your group?
9.
All of you are muted. Huh? 10
9
je?
people, Doctor.
9 including me 10 lah. So everybody's here, right?
Everyone is here.
Okay. Last posting was medical, right? The
Yes.
last posting was medical, right?
Yes, Doctor.
The last posting was medical, right? The posting before that.
Yes.
Were you guys in the ward at all or langsung tak ada? Masa MCO? Masa sempat masuk ward sebelum MCO ke tak?
Sempat sehari je sebelum MCO.
So the whole medical posting was online, is it?
We do go to ward, tapi only 6 people at one time.
That doesn't answer my question. So the whole of MCO, how long were you guys in the ward? The whole of your medical posting, I mean. How long were you guys in the ward?
About 3 weeks. Got 3, 4 weeks.
Okay. Yeah, I'm trying to look for my own. Did I have you guys during third years for examination techniques? Ada tak? Saya tak ada. Saya tak ingat. Lama sangat. Masa third year, the first week usually they have examination technique kan? Okay, did I take your group or not? Cannot remember.
Cannot remember,
Did I
Doctor.
take your group and show you videos? Yes or no?
Cannot remember.
Yes or no? Because if you have, then I won't show you the same videos. If you haven't, then I'll show you.
For my
Ingat? Ingat?
for my
9 orang semua kat sini nak ingat?
for my group no.
Okay, fine. Yeah. Let me look for that thing. Okay. Tak apa. Siapa yang nak present dulu? Who's presenting?
Saya dengan Amira. Okay, so saya present ni, Doktor.
Jatuh.
Jatuh. Okay, so everyone see my slide. Okay, so this is my slide. So I start lah. Okay, so my chief complaint, my patients, Haziq, 13 years old, Malay boy, was referred from Hospital Romping to HTAA with chief complaint of facial puffiness, which associated with lower limb swelling and headache for 3 days duration. So for the history of presenting illness, 3 days prior to admission, this patient complained of facial puffiness and bilateral periorbital swelling, which is sudden in nature, noticed by his mother upon waking up in the morning, and it is not associated with overlying skin changes, and it is not warm. It is prominent in the morning and gradually resolved, and there is no recent history of insect bite, non-allergic towards food or drugs. It is associated with tea-coloured and clotty urine, which is persists throughout urination, and there is no fresh blood or blood clots noted in the urine. There is no recent ingestion of beetroots or drugs. It is also associated with reduced urine output. Previously, normal, he would urinate 5 to 6 times per day. However, in these 3 days, he urinate 1 to 2 times per day, which is reduced in output. Okay. However, there is no dysuria, there is no urgency, or there is no increasing frequency or hesitancy in urination. There is no forced smelling urine. There is no loin pain during urination. Okay. Apart from that, he also complained of headache, which is sudden, or being persistent in nature. and it is localized at the occipital region. There is no aggravating factor or relieving factor for the headache, and it is rate 6/10 in the pain score. He also complained of blurry of vision and also vomiting. The vomiting, it is non-projectile vomiting. He vomit 2 to 3 times per day for this 3 days. And then every time he vomit, he will vomit out half a cup per episode. And the vomiters contain food particle with no blood or bile stain. However, there is no diplopia, neck stiffness, photosensitivity or altered behavior in this 3 days duration. Okay, on the day of admission, the swelling become worsen as he noticed that he had bilateral lower limb swelling. It is still the mid-shin level, heating and painless. There is no associated skin changes and not warm to touch. And it started at distal extremity and then progressed proximally until the mid-shin. However, he was still able to ambulate. There is no history of scrotal swelling, shortness of breath, abdominal distension or weight gain. And there is no history of cardiovascular disease, chest pain, orthopnea, paroxysmal nocturnal dyspnea or reduced effort tolerance for the past days. And there is no abdominal pain, yellowish discoloration of sclera, and there is no previous history of chronic liver disease. There is no history that suggests of rashes, alopecia, arthritis or oral ulcer. And this is the first time presentation of facial puffiness. And there is no family history of renal disease or autoimmune in the family. Further questioning revealed that this patient had history of skin infection, which is 3 weeks prior to this presentation, and it affected his bilateral hand and feet. He complained of multiple rashes with yellowish discharge upon rupture, and gradually it became crusted. He went to the general practitioner and get topical medication and antibiotic. However, he was not compliant to the antibiotic given. He also had history of sore throat 1 week prior, which associated with on and off fever, and also URTI symptoms, which he had runny nose. He then go to hospital on pain for further management and investigation. And in urine test, he was told to have blood and protein in the urine, and his blood pressure noted that is high, is 186/80 millimeter mercury. And then he was further given medication and referred to HTAA for further management. However, in the ambulance, he developed sudden onset of seizure, which characterized by sudden jerking of both upper and lower lip, uprolling of the eyes, and also drooling of the saliva. So the episode of seizure lasted for 2 minutes and aborted spontaneously. There is no twitching of face, chewing, lip smacking, tongue biting, bowel or urinary incontinence, and there is no breathing abnormalities. However, 10 minutes later, he then developed 2 episodes of seizure with the same characters and duration. And then he was given medication for the seizure. Okay. Upon arrival at the ED his blood pressure was high during that time and CT pain was done for him. There is no intracranial bleed or infarction. And then he was transferred to PICU for close observation. So this is the summary of the presentation for this patient, which is 3 weeks prior, she had skin rashes. So possibly he had impetigo during that time. And then 1 week prior, he developed sore throat and runny nose, and it is possible pharyngitis. And then 3 days prior to admission, he developed bilateral periorbital swelling and facial puffiness, and also colored urine and oliguria, which suggested PSAN. Okay, and then he also developed headache, blurred vision and vomiting, and I think it is due to secondary hypertension. Okay. On the day of admission, the swelling worsened, and he also developed seizure due to the condition. Okay, systemic review revealed no significant finding. So for the past medical and surgical history, this is the second hospitalization. He was once admitted at 2 years old due to pneumonia. Otherwise, no non-medical illness or no significant surgical history. So birth history, it is uneventful, antenatal, perinatal and postnatally. So for the nutritional history, he was on exclusive breastfeeding up to 6 months, and then mixed with formula feeding, and then weaning start at 6 months old with soft food. So currently, he had adult. He is on adult diet. Okay, for immunization history, he fulfilled his immunization schedule up to his age. And then for the family history, he is third out of 5 siblings, and there is family history of bronchial asthma and hypertension, but no family history of renal disease or autoimmune disease in the family. For the developmental history, he just finished his UPSR and passed all the subjects, and he is not active in sports and co-curricular activity in the school. Okay, and then he was able to make friends. So for the social history, he lived with his family at Tanah Putih, Rompin. His father worked as cleaner at Hospital Rompin, while mother worked as promoter. The total income per month is about 3,000, and it is sufficient. Okay, so that's all for my history. Next, I'll proceed to the physical examination. The physical examination was spent on day 16 of admission. For the general examination, he was conscious, alert and comfortable. There is granula attached to the dorsal part of left hand without any infection. For the peripheral, for the anthropometric measurement, his weight is 29 kg with height of 141 cm. So for the vital sign, his blood pressure is quite high, 121 over 72 mm mercury, with pulse rate of 72 beats per minute, respiratory rate 22 breaths per minute, and temperature he is febrile. So for the peripheral examination, there is no pallor, jaundice or rash threat. So for the mouth, oral hygiene was fair and good hydration status. Sensor and pharynx not injected. There is no rash on the skin, and there is no bipolar edema noted. Okay, for the abdominal examination, inspection moved with respiration, non-distended, no scar or abnormality noted, umbilicus located centrally and inverted, so palpation soft and non-tender, and no abnormality detected. So for the neurological examination, nasochroma skin full with level 50. There is no muscle wasting or fasciculation, normal muscle tone and power, and also reflexes for both upper limb and lower limb. Sensation intact. So there is no abnormality detected during this time. So other systems will unimated. So for my summary, Haziq 13 years old Malay boy with history of vertigo and pharyngitis, 3 weeks prior to admission, who currently presented with facial puffiness, with bilateral periorbital edema, with associated with oliguria, hematuria and symptoms of hypertension for 3 days duration. On the day of admission, he developed bilateral pupillary edema and tonic seizure. Otherwise, there is no other symptom of lower urinary tract symptom, no skin rashes, no joint pain or abdominal pain complained by the patient. Physical examination on day 16 revealed elevated blood pressure with no other abnormal findings. Okay, so my provisional diagnosis would be post-streptococcal acute glomerular nephritis, which is complicated with hypertensive encephalopathy. So I had several points for this diagnosis, which is this patient had history of impetigo before, impetigo and also pharyngitis, and the symptoms itself go towards post-streptococcal acute glomerular nephritis. This patient had facial puffiness, bilateral lower limb swelling, oliguria, hematuria, and also symptom of high blood pressure. And on day of admission, he had generalized tonic-clonic seizure as complication of hypertension. Okay, so this is my differential diagnosis. So first is the IgA. So mainly it is causes of secondary hypertension. So first is the IgA nephropathy, because the symptoms itself, and also this patient had history of recent URTI. But this patient does not have family history of renal disease in the family. Okay. And then next is heinous colon purpura, because this patient had edema. Okay. And then this patient had hypertension and hematuria and proteinuria. And then he also had recent history of URTI. But this patient did not have any rash, any arthralgia or abdominal pain. Next is urinary tract infection. This is a point against. Next is the lupus nephritis, which the patient had hematuria and proteinuria, and then disease itself included in the sleep criteria. However, this patient is the points against. He is a male, and there is no history of alopecia, myalgia, or arthritis. Okay, next, because this patient complained of seizure, so I'm thinking of meningeal encephalitis. Okay, so this is my points against. So next we go to the investigation. Several investigation was done. So first is full blood count. In the full blood count, there is evidence of leukocytosis, TWBC high.
Stop. Let's just ignore the investigation. It's just based on your provisional and your differential diagnosis. What investigations would you do? You just ignore it.
Okay, so first I like to do the full blood count. Okay, because I want to look for evidence of any infection. So I would like to look for leukocytosis. And then with what predominant cell, if it is neutrophilia, so I suggest bacterial infection. If lymphocytosis, so I suggest viral infection. Okay, so next I would like to do urine.
Anything else you look up?
Huh?
Anything else you will look up for in SEC?
I would like to look for the hemoglobin.
Okay, what about the hemoglobin?
I think hemoglobin, because his patient had hematuria, suggestive of hematuria. So I'm thinking of hemoglobin level.
What about the level?
Reduce due to the hematuria if the hematuria is massive.
Okay, but usually you are really less likely to get anemia from a hematuria caused by an AGM, isn't it? Right? Definitely your differential is a nephrotic syndrome, right? Your differential is IgA nephropathy, your nephrotic is also there, right? Okay, can nephrotic syndrome present with seizures? Can not?
Sorry, doctor, I cannot.
Can nephrotic syndrome present with seizures?
Nephrotic syndrome. I think it can.
Can a nephrotic syndrome present with seizures?
I think can if this patient had hypertension.
Is that the only reason why they may present with seizures? Any of you? In nephrotic, we're not talking about AGM, we're talking about nephrotic syndrome. Why else would they present with seizures apart from it being a hypertensive crisis, a result of a hypertensive crisis in nephrotic syndrome? Atypical presentation, but they can present, isn't it? Right? So why?
Sorry, doctor. I'm not sure. How about others?
What happens to the blood in nephrotic syndrome? What happens to your hematocrit level?
Increase.
Nephrotic syndrome. What happens to your hematocrit levels in nephrotic syndrome?
Increase.
So they are puffy, right? But intravascularly, are they depleted or overloaded? Intravascularly. Anybody? Madiha, I can see you hiding. In nephrotic syndrome, intravascularly, are you depleted or are you overloaded? The fluid goes into a third space, right? That's why they're puffy over, right? True? But intravascularly,
Depleted.
depleted, right? So depleted, that means your hemo concentrated.
More concentrated.
So your hemo concentrated, what can happen in the brain?
Thrombosis.
Thrombosis, right? They can get a thrombotic stroke, right? In nephrotic syndrome. What other in your differentials? Shafika, slide one slide back to your differentials.
This is
Okay, what other differentials here can present with a seizure also?
lupus nephritis,
Okay, fine. Another one?
meningoencephalitis.
Another one? You only left like one out of three. 30% chance of getting it right. Which other condition can present with seizures?
So intracranial bleed.
This one.
Dimension then.
Yeah. Atypical presentation, right? You get vasculitis in the brain also can present with seizures or altered sensorium, isn't it?
Yes, betul.
Okay. So FBC, if you are thinking about nephrotic syndrome as a differential, yours is not here, I think. Is it? It's not there. Yours is meningoencephalitis. Anyway, if you're thinking about nephrotic syndrome as a differential, you have to make sure you look for hemoconcentrate. Okay. Okay. What other do you do?
So I would like to do the urine to look for any hematuria or proteinuria in the urine. Okay, and then for the differential, there's also urinary tract infection. So I want to look for the nitrite level. Okay, so that is for the urine. Next, I would like to do the renal profile because if this patient had acute glomerulonephritis, the complication would be acute kidney injury. Okay, which represented by increased urea and creatinine ratio. Okay, so next, I would like to proceed with liver function test. I would like to look for the albumin level in this patient because for nephrotic and nephritic syndrome, it will be low albumin. Okay, next, I would like to do the complement level because any inflammation or infection would cause reduce in complement level. Okay, next,
Anybody? Have you found any? What? What did you say just now about the complement level?
the complement level, infection or inflammation would cause reduction in complement level. Okay, and then we will look for infection or inflammation if the complement level is
What do
increasing.
you expect to see the complement level in somebody like in somebody with ATM?
Sorry, Doctor, not clear.
What would you expect to see in the complement level of somebody with ATM? Why do you do it in somebody with ATM? If you're telling me it's decrease in any cases with inflammation, specifically why are you doing ATM?
Complement level will be decreasing
Which one will decrease in ATM?
because there is
Amira,
ongoing.
Amira, which one is decrease in ATM? Now we're talking about ATM, right? In
Yes.
ATM, complement levels, what would you expect to see?
The C3 will be low, but the C4 will be normal.
Okay, so how long will it be before it normalizes?
About 6 weeks.
Around 6 weeks.
About 6 weeks. Okay. Now, it also gives you an indication about whether you need to investigate further whether or not it's a straightforward post-strap GM. Right? If both your C3 and your C4 is reduced, clinically it's post-strap GM. You still treat as post-strap GM, isn't it? But you still need to monitor and think, if C4 is also reduced, maybe we are dealing with something else. Maybe we are dealing with connective tissue disease, right? Just because he's a boy doesn't mean he cannot get it. True? It's just that the risk of getting it, the incidence of a boy getting it is lower. The other thing is that if your C3 and C4, your C3, C4 doesn't normalize by the time you review the child in 6 weeks time. Also, you need to think about further investigating for connective tissue disease, right?
Okay, doctor.
Continue.
Okay, so next, I would like to look for anti-streptolysin O titer. Okay, because this will give a clue whether this patient had post history of streptococcal infection. So the normal it is less than 200. If it is more than 200, so we can conclude that this patient had past history of post streptococcal infection.
So basically, your ASOT is to show that there was history of a post-strep infection, isn't it? Right? And it's not an AGM secondary to something else. Shafika, go back to your differential diagnosis in your slide. Okay. Who else wants to volunteer any other investigation that you would do? Any volunteer? No? Anything else you want to do?
For lupus nephritis, we can send for anti-double stranded DNA or
Okay, you just
ANA.
okay. You just suspicious at that time, but if you think it's not wrong, you can send. Okay, if you think it's wrong, your differential. But if your C3 is low, your C4 is normal, no other indication of connective tissue disease, usually you wait until during monitoring if there is anything that to suggest that this is not a typical post-strep CN, then you do that. Okay, so the connective tissue screening KIV lah, right? Okay, so Shafika, next step. Your slide, these are the other steps.
Okay, so this is okay. So you think already done, and then because this patient also had I suspected this patient hypertension, so I would like to check for the CT brain to look for any intracranial bleeding or infarct. And then any changes of cerebral edema. And then doctor, can we do lambang puncture for this patient? Because this patient, the differential will be meningoencephalitis into this.
You have to decide on the other things first. Okay, number one, immediately post seizure, you're not going to do a lumbar puncture, right? Okay, if there is evidence of increased ICP, also you're not going to suggest to do a lumbar puncture, right?
Yes.
Clinically, if the child has no fever, leukocytes are not high, right? Otherwise, does not show any signs of meningism, then you wouldn't do a lumbar puncture, right?
Okay, so my final diagnosis will be post-streptococcus acute glomerulonephritis, complicated with acute kidney injury and hypertensive encephalopathy with posterior reversible encephalopathy syndrome. Okay, so for my management, because I highlighted that this patient had these problems, which is the post-streptococcal glomerulonephritis, hypertensive encephalopathy, and also acute kidney injury. So my management would be for this problem, to manage this problem. So for the post-streptococcal glomerulonephritis, so first resuscitation, if this patient had reduced BP ataupun this patient had high BP kan. Okay. So first resuscitation, and then we need to monitor first the fluid intake, urine output, daily weight, and also BP for hourly. So this is the nephrotic chart actually, and then we also need to monitor the temperature and seizure for this patient. Next for the medications, as this patient had post-streptococcal glomerulonephritis, so we give antibiotic for this patient, penicillin, for 10 days duration, and this patient also had hypertension, so I would like to give antihypertensive drug for BP stabilization. So other than that, this patient also had edema, so we had to reduce the edema. So first, first with restriction and also diuretics. Okay, for the diet, I will advise the patient short restriction diet. but protein acid shield is unnecessary. So we also need to monitor and watch out for the complications, hypertensive encephalopathy, pulmonary edema, and also acute renal failure, and manage the complications according to the complications. So this is for the post-streptococcal glomerulonephritis. Okay, so next for the hypertensive encephalopathy, this patient had there is red flag symptoms and signs which require urgent investigation and management for the hypertension. So this patient had red flags of headache, vomiting, and also this patient has seizure. So we may think of an organ dysfunction, which is a hypertensive encephalopathy, which we need to investigate and manage early. So this is other red flags, endoscopy, and also symptoms of cardiac failure. But doctor, fundoscopy is not indicated acute masa hypertension tu kan doktor?
You see, what are you talking about? Looking for hypertensive vascular failure?
Because I want to see is there any evidence of increased ICP?
You do the fundoscopy to look for increased ICP, but you are talking about hypertensive vascular changes, you don't get any acute setting. But if the child presented with a seizure, you're in the peripheral, kat klinik kesihatan, ada CT pun tak? Tak ada kan? So, what do you do? Fundoscope, right?
Yes. Can we do it in acute setting, doctor?
Yes, why not?
So, we are not afraid of inducing stress to the patient tu.
What would a light shining into the eye induce? How would that induce stress? What type of fundoscope are you talking about? Fundoscope, you know your normal fundoscope, how would you induce stress? Or honestly, how would you induce stress? How is using a fundoscope any more stress inducing than treating the patient and drawing blood?
There's nothing stressful for the patient because you always see the eyes.
You're just shining a light into the eyes. What are you so worried about? Inducing stress until the child gets another seizure. Until the BP shoots up and then gets another seizure. No, right? Fundoscope is basically shining an eye into shining a light into the patient's eyes. I don't see how that can induce stress. Okay, you're not talking about sending the patient to the eye clinic for formal assessment, isn't it? It's just you looking into the eye to make sure there's no increase intracranial pressure. What if the child gets screaming with a history of seizure? How do you know that it's post-strep GN and the child didn't actually have a brain aneurysm and actually started bleeding out? You get what I mean? Well, you still need to do a fundoscope. In the casualty, they do a fundoscope, but they don't know. They do, right? Yes or no? Anggap atau grading, I can see all your faces right now. In the casualty, they do fundoscope, right? Anybody who comes with a seizure, irrespective of cause, you still do a fundoscope, right? Yes or no? Yes or no?
Doctor.
Yes.
Yes.
Yeah, anybody who comes with a seizure to the casualty, you will do a fundoscope, yes, right?
Yes.
I don't see how that induces stress.
So we will proceed to the hypertensive encephalopathy. So this is the definition of hypertensive encephalopathy. Characterized by severe BP elevation with cerebral edema, and there is neurological symptoms like lethargy, coma, or seizure. And then is to be MPE. So likewise, we had to do fundoscopy examination and neurological clinical evaluation. So for investigation, we need to do CT brain to explain hemorrhage. And then MRI for edema. Okay, so this is the layout of management for the hypertensive emergency. So we need to admit the patient to ICU or hydrogen ward, and then we need to gain the vascular access. Okay, then monitor the neurological status, cardiac and continuous BP monitoring, and also the urine output. And then if this patient develop any serious complication, so we manage the complication. If the patient had an seizure, so we can give anticonvulsant along with the antihypertensive. And then for the lowering of the blood pressure, we need to do it calmly but gradually, because if we reduce the BP aggressively, it may precipitate ICD. Okay? And then the initial goal to reduce NAP is we want to reduce the NAP by 25% over the first 24 hours. And then for the drugs, so IV drugs is more preferable and continuous infusion, such as IV labetalol. Okay, so for the acute kidney injury, for the acute glomerulonephritis, usually only marginal impairment. It is common. However, the uncommon one is a severe persistent oliguria or anuria with isopenia. So how can we manage the acute kidney injury? So we need to tackle the hypertension first. So we need to stabilize the BP, the BP monitoring, and then give antihypertensive drugs. Okay? And then if needed, so we give the diuretic and then fluid restriction for the acute kidney injury. Okay, so that's all for my presentation.
Of course, at the end, the treatment is actually just a topic, isn't it? So what is the natural history? How long does it take for the post-rap GM to resolve? Symptom-wise, anybody?
If hematuria more than 6 months.
6 months? We're talking about growth of microscopic. Usually how long does it take for the symptoms to resolve?
For the hematuria, it takes 1 year.
What hematuria? Growth, macroscopic or microscopic? Growth or micro? The microscopic hematuria takes how long to resolve usually? Hypertension takes how long to resolve usually? What's the natural history?
Hypertension usually need 2 to 3 weeks, doctor, to resolve.
So the whole thing is usually symptom-wise, usually it's about 2 to 3 weeks, right? So by 2 to 3 weeks, the hypertension should have resolved, the renal function should have started to return to normal. The macroscopic, the gross hematuria should no longer be gross, right? So if you have persistent gross hematuria after about 2 weeks worth of symptoms, then you need to investigate further, whether it's an IgA nephropathy or something else. So roughly it takes about symptom-wise. Symptom is what the patient experiences, right? So gross hematuria is what they experience, isn't it? Right? Hypertension, renal dysfunction, so renal impairment. So that's roughly about 2 to 3 weeks, right? So the gross hematuria shouldn't last more than 2 weeks. Biochemically, C3, C4 should return to normal by 6 weeks, right? By 2 to 3 weeks, your renal function should be at least approaching normal. So usually what you do, you see them, if the child gets discharged, what's the criteria for discharge? Normal renal function, right? Normotensive without the use of antihypertensive, right? And no more gross hematuria. So that's the criteria for discharge. You don't need, the child doesn't need to stay in the ward like for 2 or 3 weeks. Once the child's gross hematuria has resolved, the BP is normotensive without any antihypertensive, and the renal function is nearing normal, then you can discharge the child. So usually what you do is you see the child at 2 weeks time. Make sure that there is no gross hematuria. The urine looks grossly clear. Then you see them about 6 weeks time. That's when you need to repeat all your complement levels, your renal function. Your renal function is nutrient, so by the way, you have to repeat and check your BP as well, right? But by 6 weeks, they should normalize. If it doesn't normalize, then you need to investigate. Now, gross hematuria, 2 to 3 weeks only, right? At the microscopic hematuria can last up to 2 years post-GM, right? Microscopic. So if it's persistent after 2 years, then you need to investigate lah. this being said that it's just microscopic, hematuria doesn't have anything else like proteinuria in it, right? And no other symptoms lah. But usually microscopic can last until roughly about 2 weeks, 2 years. So usually in the follow-up clinic, you follow up until the urine FENE is clear. Understand or not? Okay. Now who's presenting the second one? Who's presenting the second one?
Me, Dr. Amira.
Mira, what system is it?
Hematological, Dr.
No, nobody's sharing a screen, right? Have you guys watched this before?
Watch apa, Doktor?
You sharing? I'm sharing, right? Have you guys watched this before?
No, Doctor.
No, the newborn exam. This was World Park Hospital, and I think we can start. Have you guys watched this before?
No, Doktor.
Not yet.
No.
No. So I guess I didn't take you for in third year lah. You wanna watch this first, or you want Amira to present first? Wanna watch this first, or you want Amira to present first?
Watch first, Dr.
Watch first.
Anyway, we answer this. So. Good morning, Sophie. And this is Alex. And I think it's his abdomen that we need to check down this morning. So if we're all Park Hospital, then I think we can start. Okay. The first thing I'm going to do is just simply observe Alex and just see him sitting on the bed there. And I can see that he looks nice and comfortable, he's alert, he's quite lively, and I can also see that his gut colour is nice and pink, and he doesn't look pale or jaundiced, for example. He's not got any excessive pigment such as drips or medications or anything of that nature. Moving to look at his hands, if I look at them fairly closely, I can see they're a good colour, they're also nice and pink, they feel nice and warm, and I'm going to do a capillary recent time that shows it was, and that was less than 2 seconds. Okay, so his perfusion is fine. We're then going to check his hydration. I'm just looking in his mouth, and I'm going to look in there, see if I'm not on it. And that looks lovely and moist. His eyes look nice and moist, and they're not symptom. And if I do a skin further, I can see that skin is absolutely nice. It's very well hydrated. So that concludes my first set of observations, and now I want to just tell it. And for that, I need to just lie you down a little bit. Is that okay? If you just lie back. Well done. There you go. Whee. All right. So, can I lift this up a bit? So lift this up like that. So we're lifting it up just so that we can see the margins there. Is that all right? So, thank you. So, starting my next lot of observations, I can see that his tummy looks nice and flat, it isn't distended, there aren't any scars, and it's moving nicely. Thank you. It's moving nicely with respiration, which tells me that his tummy's not hurting at all. I'm next going to do superficial palpation, so just gently feeling around the tummy, goes all the way around, making sure I'm feeling all 9 areas of the abdomen. And what I'm mainly doing here is checking to see if it hurts anywhere. So I'm not really looking at his abdomen, I'm more looking at his face to see if it's tender anywhere. And it certainly doesn't seem to be tender, and I can't feel any hard areas or any guarding. So that's fine. After superficial palpation, go on to deep palpation, and I'm crossing the right iliac fossa, and we palpate gently with each of his respirations, moving up towards his liver, and ending with your index finger parallel to his rib margin. And I can just feel the tip of his liver there, which is perfectly normal in a child of his age. right cardiac fossa. We then move around in the same way, palpating deeply for its spleen, breathing, feeling in between each of his breaths, and again ending up with the index finger parallel to his rib margin. I can't feel the spleen. Sometimes a little spleen at the back you can feel by just coming forward in that way, but there's still no spleen there, and that is absolutely normal. If the liver or spleen were palpable, I would follow this up with percussion to help to estimate the size of the enlargement. I'm now going to auscultate his abdomen. And that all sounds fine. We'll just check down in the hernial orifices, and that looks absolutely fine. No sign of any hernias already looked above. Normally at this stage we would also check the external genitalia, but we've already done that previously on Alex, and we know that everything's fine there, so we don't need to do that today. One final thing, if we were examining a young baby who's been napped, it will be important to start the abdominal examination with the nappy open right from the start. But with a young man of Alex's age, which is 3, it's important to examine it in a tentative manner so that we open the top area first, and then we can see the external genitalia aspirated stage. Remember, when examining the abdomen, to start with general observations, including the general well-being and colour of the child, note any accessory equipment, and note the procedures and hydration status. Then move on to specific observations of the abdomen, including noting any discomfort, any masses or scars, and how it moves with respiration. Okay. Now. Good morning, Sophie. And this is Alex. And I think it is abdomen that we needed to examine this morning. So if we're all quite comfortable, then I think we can start. Okay, now, first. Okay, the first thing I'm going to do is just explain jaundice, for example. When you, okay, when you, let's look at everybody else. Okay, when you examine, right, abdomen will be flat with 1 kilo. Okay, he doesn't have a kilo here. I think that's why it's slightly elevated here. But that being said, when you feel the wall, and I'm going to particularly. So that being said, when you lie the patient down, let's just say for whatever reason the patient cannot lie flat down, whether there's gross ascites, and then the child is breathless if you lie down, make sure that your abdomen, is in a straight line, kind of like, make sure that your abdomen is in a straight line and you don't hunch. Right? Let's just say if the child cannot lie flat straight, make sure that the child's abdomen would be here. That means you are bending from the butt. So this part is relatively in a flat position. You get what I mean? Rather than sometimes you don't position the child properly. So what happens is that the child is like, then the stomach ends up there. You get what I mean now? Right? Make sure that if let's say you cannot make the child totally flat, right? That when you bend, when the child is sitting, make sure that it's the hip is the one that's an angle, so that the rest of your abdomen is flat. You get what I mean now? Rather than if the child is too low, what happens is the abdomen goes down here, right? Then your butt is here, right? So there's a curvature. So when you want to examine the abdomen, your abdomen is actually curved. You get what I mean, huh? That means the child's hips must be at where the curvature is, not too low, and the abdomen is where it's bent. So like here you can see that his rib all the way up to his hips is actually a straight line. It's not a curved line, right? The other thing is that when you palpate, remember that your hand has to be level with the abdomen. So make sure that you get either you squat down or you get a chest set. Yeah. She skipped certain things like ascites, fluid fill, and shifting downers. That's because this is for postgraduate level, and I think then you can see that the abdomen is not distended. But for your level, make sure that you just take a note and at least do shifting downers, right? Just to make sure that there's no ascites. Okay. You want to continue with Amira? Then you can watch the one with ascites, I think. Okay, the one. This one. Any questions? Not? If not, we continue Amira first. Nope. Okay. Yeah. Okay.
Okay, Doctor, I start presenting now. So, my patient, Muhammad Faris, a 12-year-old Malay boy with underlying beta thalassemia major, presented to DK of HTA for regular blood transfusion. So, history was taken from his biological mother. The history started when he was 1 year old, in which his mother noticed that her son became less active compared to the other children, because during at this age, her son already started to crawl but became less active. And she also noticed that her son appeared to be pale. Otherwise, there was no rapid breathing, shortness of breath, or bluish discoloration, and there was no symptoms of URTI that may suggest the lethargy symptoms. And then, due to concerning about her son's condition, his mother brought to the hospital and was told that her son's hemoglobin was low at that time. So the patient need 1 pint of blood transfusion and the symptoms improved. And a few investigation was done and revealed that he has beta thalassemia major. However, mother claimed that both parents never done screening before, and it was a non-consanguineous marriage. And then during that time, mother was screened for beta thalassemia and noted to be a beta thalassemia carrier. However, the father was not screened because the parents were already separated during that time. And since the age,
what do you think? Father not screened? Obviously, the father is a
carrier. Yes.
carrier, right? If not, why
Yes.
the kid, right? Okay.
So since that time until 4 years old, he need a frequent blood transfusion every 2 months. However, when he was 4 years old, he started to need more frequent blood transfusion, where he need every 2 weeks because of the anemic symptoms. And at 5 years old, he underwent splenectomy at HTA due to massive splenomegaly, in which he presented with abdominal distension and also easily fatigued. Post-splenectomy, the blood transfusion back to normal, in which every 2 months. So currently, the requirement for transfusion is every month, in which he will be transfused for 2 pints because he has become more active. his hemoglobin level pre-transfusion usually 7 to 9 gram per deciliter. And he never experienced any reaction post-transfusion such as fever or rash. And now he is an active boy, able to go to school and involved in sports. And there was no episodes of shortness of breath or dizziness to suggest anemic symptoms. And also there was no fluid overload symptoms such as leg swelling or reduced in effort tolerance. And for drug history, he started on iron chelating agent when the serum iron was about 2000. However, the mother could not remember the exact year the iron chelating agent was started. He was on subcutaneous desferrioxamine for 2 years, and patient claimed to be compliant because mother herself administered the injection, and there was no history of injection site infection. And then after 2 years, he changed to oral deferracinox. And he was also on tablet folic acid. However, the mother claimed her son is not compliant to the oral iron chelating agent, which makes the range of serum ferritin usually 1000 to 2000. He was also advised to be on strict diet where he need to reduce the iron-rich diet, but mother claimed the diet was also not being followed. However, there was no history of recurrent infection, and mother was not sure whether her son received any vaccination post-splenectomy, pre and post-splenectomy. Otherwise, currently, there was no symptoms of iron overload, such as outer bowel movements, no skin changes, and no hypothyroid symptoms. And the growth was according to... Sorry, doctor?
What medication is you on now?
Currently on oral desferracinox.
That's all?
Desferracinox.
That's all, is it?
And tablet folic acid, that's all. And penicillin V, sorry. I missed that point.
Okay.
So currently, the growth was according to the age. There was no failure to thrive, and blood screening for infective blood screening was non-reactive, and he was on annual screening for eye, hearing, and also cardiac assessment for iron overload. So antepartum and postpartum, it was uneventful, and he was born at term 38 weeks via SVD, and the birth weight of 3.2 kilogram, which is normal. So he was breastfed up till 2 years and started weaning at 6 months old, and currently he was on a normal adult diet with no rich iron diet restriction. So he has completed all the immunization schedule, and he is currently has completed her standard 6 at primary school in Pekan. He is an average student, and he just finished UPSR during the time clerking and waiting for result. And for family and social history, he is the only child for both of his parents. His parents separated before he was 1 year old. And the mother had second marriage, and he has 4 step siblings. His stepfather and siblings had done screening and all turned to be normal. Currently, he lives with his mother, stepfather, and also step siblings in Pekan in rented house. And his stepfather is a self-employed with income of RM 750 per month. The family also received assistance from Jabatan Kebajikan Masyarakat, RM 350 per month. So in physical examination, generally patient is conscious and alert. The physical examination was done before blood transfusion. So he appeared pale. However, there was no respiratory distress, no thalassaemic phases such as frontal bossing or prominent maxilla, and there was no skin hyperpigmentation. The vital signs all were normal, and the weight and height were all within the normal centile. For abdominal examination, there was surgical scar noted at the left upper quadrant, measuring about 9 centimeter. However, there was no bruises, dilated vein noted. There was hepatomegaly on palpation with the liver is palpable 2 finger breadth below the right costal margin with liver span of 13 centimeter. However, there was no sign of ascites where the shifting dullness and fluid were negative and normal bowel sound was heard. And for cardiovascular examination, there was no sign of heart failure such as cardiomegaly, and there was no murmur. So based on the history and also physical examination, so my provisional diagnosis is transfusion dependent beta thalassemia major with iron overload and also a history of splenectomy.
Okay. It's pretty much straightforward, isn't it?
Yes, I do.
Beta thalassemia major. You guys must know. You guys must know what's the basic abnormality, right? So beta thalassemia, that means which chain is missing? Which chain is missing?
Oh, which one is missing? The HbA is low, Doctor.
Yeah, which chain is missing? The beta chain or the alpha chain?
Beta.
The beta chain.
Beta globin.
The beta chain is left, right? Tak cukup,
Yes.
right? Depends on
Yeah.
whether it's a major or minor. Right? Alpha would be the alpha, right? The basic thing you guys must know, because if you tell me which gene is involved, but you cannot tell me which chain is involved, then that's a problem, isn't it? You get what I mean now?
Yes.
Right? What's the inheritance?
It is autosomal recessive.
Yeah, that also must know, right? So like I said, if you know the the gene that's involved, but you don't know that autosomal recessive, also that's going to be a problem. You guys must know the basic facts before you go into details. So mother is a carrier, mother is a trait. Obviously, the biological father is also a carrier, isn't it? Right?
Yes.
No, this before marriage, you have to screen, right?
Yes, now
Yes
we
or
need
no?
to screen for thalassemia. Okay.
It's only for the Muslim community, right?
I think
Muslim
so.
community, right?
I think so,
I
Doctor.
think non-Muslim tak payah kan? I don't think so. Yeah, tak payah lah. It's only the Muslim community needs to screen. Why actually? Do you
Actually,
think about it?
compulsory, Doctor.
Huh?
Also
Sorry?
not compulsory for Muslim. So
compulsory,
it is additional test we can do.
Because the other question comes if you are both carriers. The other question is what you're going to do about it, so right? True, not? Whether it's worth going through with the marriage or finding somebody else, right? True, not? Because if you go through with the marriage, then you have a 1 in 4 chance of the child
Get major.
getting major, isn't it? True, not?
Yes.
And it's not like it's non-chronic illness, not causing there are lots of economic and also social what's the word for it? Consequences to having a child with special needs, isn't it? Right? So whether it's better to be tak tahu or whether to know lah, depends on what you think. Not ethics lah. Not going to talk about ethics. So know your basic things. What's beta thalassemia, what's alpha thalassemia, which when you look at your HB electrophoresis, HbA to HbF, which one is more, which one is less, that part you must know. Presentation is usually at about 18 months, isn't it? Right? That's when the blood the blood is almost totally switched from HbF to HbA, isn't it? Right? Okay. Pre-transfusion by right should be 9 to 10, but I know in Malaysia, somehow or other it doesn't happen. You need it so that you can suppress extramedullary hemophoresis, right? So that you don't get all the extra things that you see last time with the chipmunk faces, right? Mandibular maxillary protrusions, the frontal bossing. Nowadays you tend not to see it because nowadays you transfuse quite well but sometimes you do see it though, especially if the patient hasn't been transfused well. You only see nowadays in I think the grown-up patients with thalassemia, no longer in the kiddos. Okay. Now, any questions? No question? You want to watch a video or you want to finish it up?
Doctor, one last question. Since this patient is already on oral iron chelating agent, however, the serum ferritin is still high, so patient still have potential for iron overload.
He's not compliant, right?
Yeah, so
we have to push compliance.
We need to encourage.
You have to educate the mother first. You have to tell the mother why it's important. What's education is key, isn't it? Right? The more you know, the more well informed you are, the better you can make your decision. Tell her why iron overload is such a problem. Right? Then you just have to push, because if he's not compliant to the oral, I doubt he's taking his penicillin B also. I doubt he's taking his penicillin also. I doubt he's taking his folic acid.
Yes.
True. 3 tablets per day, so the penicillin is twice per day. The penicillin, at least if he's not compliant, then you can ask them to go for injectable. But then on the other hand, if the iron chelating agent, if you go back to the injectable one also, he's not compliant with oral already, you think he's going to be compliant with injectable. It's more painful to inject, isn't it? Right? You need to push compliance first. It's the same thing now with adults with diabetes and hypertension. If they are not compliant, is it worth changing their medication? No, isn't it? It's only worth changing if it's like they are not compliant because it's 4 times a day or 3 times a day, or they got 3 different types of medication taken like 3 times a day. Right? It's worth changing to something that is more easy to take, like once a day medication. Then that is worth changing. But if it's already once a day medication and they are already non-compliant, you can't really force them, isn't it? All you can do is educate the mother first, and then when the child grows older, educate the child also. But the mother don't understand why it's important. You basically cannot go to their house and force them to take medication each and every time, isn't it? You want to watch another video or you want to finish it up?
Video.
No, I don't know.
Watch the
video like that.
If you want to read development, there's this book.
Oh.
Mary Sheridan. Yeah. Mary Lee Sheridan, from birth to 5 years. It's this thin. It's only like minus appendix. It's only like, it's 96 pages minus the appendix. It's black and white. So I think it's probably in your library. Go get it from the library and then go photostat. Okay? It goes by years, it goes by age, and it tells you what you expect. if you want to read about development. Okay, so that's that. If you want to
Can
know
I ask
about,
my question?
yeah,
Is it recommended in thalassemia patient that receive blood transfusion to receive leukodepleted like red blood cell?
to reduce the chances of reactions here. Sorry, my Wi-Fi went wonky for a while. Anyway, development is this. If you want to read about examination techniques, it's this one, but you don't need to read the whole thing. If you have it in the for reference one on and off lah. Okay. What's the guy's name? Yeah, there, Wayne Harris. If you want to, it's this thick, you don't need to read the whole thing, honestly. Your seniors book, that one, you guys know I'm quite against it, right? If you're going to read that, make sure you read your textbook and fix whatever mistakes is in the senior book that she sells for $24. I cannot remember what's the girl's name already. You have a book, right? From your senior, right? That one has lots of wrong facts in it. So if you're gonna use that, make sure you read your textbook first and fix whatever is wrong. But then it's easier for you to learn something correctly the first time than for you to try to correct a mistake. True or not? Okay. If you see this book in the library, it's worth checking it out. If you see this in the library, it's worth checking it out. Okay. It's like one page for one condition. Right? So it's just one page. If you see in the library, just borrow it and just take a look. Right? I know lately you guys have been using the UM medical students one, the thick one. I haven't gone through that book before yet, so I can't really comment on it. Okay, so let's watch one more video and then settle. Since we just did the screen one, much more do the screen one. So immediately you guys can see, right? Frontal bossing, a bit of maxillary protuberance, right? Which to suggest wait, am I sharing? Yeah. Okay. So immediately with this girl, you can see, right? There's a bit of frontal bossing and there's a bit of maxillary protuberance there.
Hi, Donna. Hi, my name's Emma. I'm the doctor. I'm coming to your son and check it. Okay? And it's your mum that you got with you. Is that okay with you? You can have a look at the other recording. Yeah, no, it's sometimes sore at the moment. Does it hurt? Yeah. Okay. Do you think you could settle over there for me so I can put your bottom back against the door? Good girl, well done. Very good. A little bit more. Okay, good girl. Next round. Okay, so any of you tipping please? I don't think you have. Have a look at your hands and I think they have one. Good girl. Okay. Well done. You stick your fingers up in the air like that. And sit, and then down to the ground, and then stick them together. Good girl. Well done. Okay. Put your hand down. You can have somebody. You can see what's the doctor for the night. Can you copy this one? Yeah, then. And look up and see me. Good girl. Well done. Can you stick your hand up for me? Stick that. There's me now. Wait. Good girl. Okay, put it back to me. Okay, so you look up and say, I'm sorry that we don't do this today. Feel all my hands up. And still feel it at the top of your neck, okay? You tell me if anything will go out to your point. Okay. I don't see no effect. Okay? You have a big look down so I can see the top of your chest. Put your hands up to the okay. So you lift your top up so you can see your tummy. Lots of layers so that you go down the right. Good girl. Okay, so I'm going to lie the bed completely flat like this and just sleep. Yeah? Oh, lovely your hair. You could get those here. Oh, nice. Very, very good. Very good. Okay, let's have a little look. Let's take a look at your tummy. Now what I'm going to do then is to feel the tummy, and then you can tell me if that's I'll be really good. Just again. Very good. Very good. Yeah. Okay. Let's put it into the sun. Okay. Can you take some breaths for me? Well done, well done. You've done this before, haven't you? Good girl. Okay. And you don't have to walk. Well, good girl. I'm still trying to look at your drum. Okay.
Doctor, sorry, we cannot hear your voice.
So that would just be sphenomegaly. So that would just be sphenomegaly. Now, the differences between the spleen, the liver, and the abdominal mass, you guys must know how to differentiate, and also a kidney, right? That part you guys must know how to differentiate. This year already, don't need to repeat all over again. Yeah? So this website usually if you want to look at videos on YouTube, you look at the ones that come from universities, or the one that I just showed you, that one comes from the MRCPCH website, the one for postgraduate pediatric certification. So generally, you can just watch that. Since you guys haven't been doing watch for so long, you haven't touched patients in so long also. Might be good just for a refresher course. Okay. Lots of other ones there, I think. There's a whole playlist, I think. In between streaming the music videos that you usually watch, you just watch one or two in between. Yeah. It's like 5 minutes per 10 minutes per video. In between watching, I don't know what you guys are watching nowadays. And in between streaming whatever YouTube videos that you're watching, just go through it and watch it. This one is the MRCPCH one. Let me see whether I can get. Yeah. Now this one is the MRCPCH one. Where is it? Now this is the MRCPCH one. Right. Now they have a lot of other ones to do. Now this being said, I have not watched every single video on YouTube, so you may or may not get things that are weird, but usually these are reputable ones. So that's one. This is American. I think this is American. So this one is a bit more. Yeah, this is American. So it might be, in terms of management, might be a slightly different. And this one doesn't have much in terms of examination techniques, but got small things like, like this one, basic cardiac anatomy. It's like 6 minutes. In between streaming, in between watching whatever you're watching, just click on this one, isn't it? Right. You've got small things like that. You've got you've got things like this that you can just go through. Alright. That being said, for presentation, don't go and copy and paste in your presentation from YouTube. So these are some of the websites you can look at. The other one would be just not that one. It will be this one just now I showed you already. Now other ones would be not this one. This is their hospital website. There's a few others, but anyway, when you go through things like that, things done by like individuals, right? You have to watch and decide for yourself whether it's reputable or not. Okay. Things done by medical students, sorry, but things done by medical students, right? Also, you better be careful when you watch. Okay. Uh, I think this is medical student. I don't know how to do it. Yeah, this one is not. This one is just I think it's a medical student, right? Like this would be some from universities. Things like this would be individual, so you watch just for the sake of watching, but don't take this as totally factual lah. You get what I mean? Things like this is all from like individuals who do it, so don't take it as totally factual. If something is wrong, then you better check with your books. Okay. So that's some of the online resources thingies that you're not. University of Leicester is just now the other one, which would be this one. Now you have to go through it lah. But anyway, it's there lah. They do a few. Okay. This one is USM, I think. Anyway, you guys can search by yourself lah. But those two websites, those two YouTube sites lah, that usually I watch lah. It's either this one or the other one. Okay. Okay. If you need a refresher, you just watch a video for a while lah. Okay. Okay. Bye bye.
Thank you, Doctor.
What is anything else? Not?
Thank you, Doctor.
Bye bye.
Bye.
Thank you, Doctor.
Thank you, Doctor. Kak Mira.